All right, I think we're gonna go ahead and get started. Thank you guys very much for coming. I really appreciate on a Saturday morning at 7 a.m. To come. That is very gracious of everyone. So just a little bit about me. I am what I would say, Dr. Serena would say, I am a woundologist. So I deal with chronic wounds all day, every day. For the past approximately 20 years, I'm in the Las Vegas area. We have our own practice of about approximately 15 different clinicians, and we see patients across the entire gamut of wound healing. So we see patients in the acute care, LTACs, all the post-acutes, outpatient wound centers. We have our own offices, 3 of our own offices as well, and we have a multi-specialty group as well. So what exactly is near-infrared spectroscopy? What are we doing? Why do we have it? What are we thinking about? And those of us who've been practicing for a number of years have seen the evolution of oxygenation and how we are evaluating that. Going through the basic sciences of this is sometimes a little bit belaboring, and we'll go a little bit more into the case series on how to utilize it, because I do think that there's a learning curve for those of us who are clinicians on how to use it. But this is very important for you to understand that we're not only just looking at macrovascular flow, we're looking at the microvascular flow. And I think we spend an exorbitant amount of time talking about how we can reinstitute blood flow to the area, where interventions, what kinds of interventions. But I think we also need to start thinking about our end organ tissue perfusion. Are we really getting the end organ value? And I don't think we think of skin as an organ and what we need to be doing for that. So just to give you a little bit of background on the colors that you're going to see. So low oxygenation saturation will fluoresce blue. What does that mean? That means that there's decreased oxygen supply, so decreased local perfusion. That does not always necessarily mean that there is some sort of massive blockage in a macrovascular artery, but it could mean that you have decreased cardiac output. It could be anemia. It could be a variety of tissue, skin dermatological disorders. So you do need to think very critically as to what your differential diagnosis is when you're looking and evaluating these pictures. High oxygenation, it will fluoresce red. And so what does that mean? Increased oxygen delivery. So we utilize this in many different ways. And obviously one would be revascularization, pre and post intervention. Could we see an immediate improvement in that tissue oxygenation there? Yes, we can. Any kind of therapeutic tissue intervention. So we use a plethora now of very, very expensive, high-end advanced products, right? And I have utilized now the machine. We use it in our practice on an everyday basis, and I use it also to justify to those insurance companies, to justify my clinical outcomes on why I am using those products and when I'm using them. And I think that that's very important in our decision-making algorithm. Those of you who still practice hyperbarics, I do. We use it pre and post hyperbarics as well. It really does give you an evaluation very quickly on if you are getting the result you're looking for, and if you are not, along with your clinical acumen. Please stop and reevaluate and change your medical decision-making algorithm. Decreasing oxygenation utilization also. So if there's any mismatched perfusion, we should be astute to that. Any kind of mitochondrial dysfunction, which is really sometimes in a chronic inflammatory state, you're going to see this mitochondrial dysfunction and an inability to use the oxygen. So you may see a hyperoxygenated area. Again, the really basics of it all is that, we're able to distinguish between the oxygenated and deoxygenated blood. We do fluoresce down to a penetration of about 3 millimeters down underneath the skin dermis. We also see these are the light wavelengths that are being fluoresced. And finally, we are able to use their algorithms and in their imaging, be able to get an image that we can see. I put this up for two reasons. One is that this is something immediate that you can see. We'll actually do a demonstration today for you guys to evaluate that. If you put a tourniquet on the finger, you will see 4 different images, up to 4 different images, depending on how you look at the interface. But here you have the oxygenated blood. You have the oxygenation percentage. You have the total hemoglobin. You have the oxygenated hemoglobin, and then you can break that down even further to the deoxygenated hemoglobin. So when you see the actual interface, it's quite robust. You have a lot of features on the interface itself. It is a touch screen, so you can touch the areas that you would like to fluoresce to see what the oxygenation is. It has a measurement that you can do, and those are fairly accurate. We've gone through this quite meticulously to ensure accuracy of those measurements, and they've been actually very, very, very accurate. Those of you that are doing reconstruction or pre-intervention, I think it's very important that you can also freehand measure certain areas. So for example, if you're doing surgical management, you do need to do some mapping. You need to understand my flap. Does my flap even have where I'm potentially going? Does it have enough oxygenation for that to survive? And I think that these images are very important once you start utilizing them into your practice, that not only can you use it preoperatively for planning, but postoperatively to ensure that your surgical outcome is really truly what you're looking for. In this day and age, I know we're an international crowd, but more times than not right now here, they're judging us for our outcomes, and particularly any type of surgical outcomes, because it's costing money. I think we had a large discussion over that yesterday. And so everybody is getting a grade in some way, somehow. And so if we're utilizing certain technologies to improve our own medical decision-making algorithm, I think it's the wave of the future, and to be able to adopt that into our practice now is really the way that we're going to have to start thinking about this for the future. Here you can also click on these and you can see side-by-side comparison. You can see the image that I showed you before that has the oxygenated blood, the deoxygenated blood. You can also toggle between those, and we can show you the demonstration a little bit later. So I think the more important aspect is, how do you use this in real life? How do you use this on an everyday basis? And I really am very strongly implore you to try to implement some of these even in one half day of your clinic, or your one half day of an OR, because I think it really gives some great information. So you can see here, we had a patient prior to amputation imaging, and you can see that it's a little bit difficult, but there it shows about 40% oxygenation there and about 64 here. So nonetheless, the amputation was performed. To the naked eye, those of us, we've been practicing a long time. I think we take for granted that we have a certain clinical acumen that we know and we can predict. But I think most of us could probably agree that this didn't look terrible, and you probably couldn't demarcate exactly where the issue is really happening. And lo and behold, there really is a significant amount of decreased oxygenation there, and likely this is going to dehisce. And so could we, prior to getting out of the OR, could we release that surgical line? Do we need to put a graft? Do we need to use different surgical technique, et cetera, to avoid a postoperative complication? That's really what we're looking at. I so apologize for this picture. It's so dark. I wish I could have lightened it, but I hope that you guys can kind of look a little bit closer. But there is a large black S car here. And obviously this is a TMA. The surgeon had probably knew that she needed to have a BKA, but it is what it is. We do this all the time, right? And we're trying to salvage. And because this is such a large black S car, none of us know if that's going to survive or not. So we did an image, and lo and behold, majority of that surgical line actually had some tissue perfusion, but there was an area here that was in question. And sure enough, and this one was taken on August 9th, 2021, and this one is August 19th, which was just a few days ago. We saw the patient, and again, lo and behold, majority of this surgical line is healing, but the one area that was in question is still in question. But again, we've had variety of different interventions that we've done with the patient to ensure and instill greater oxygenation to the area. So I do anticipate that the one area will heal eventually, but it may take us a little bit more time and effort into instituting more blood flow. Vascular intervention. Once again, you know, the skin is an organ. And so are we getting end organ perfusion is really what's interesting. And I think it should be utilized in addition to post-intervention imaging. So here we can see there are no wounds here. This is a clinical claudication that the patient was coming in with. Pre-intervention, we can see that there is a significant decrease in oxygenation here. I caution those of you who are using the technology for the first time and only looking at colors. I do think that the colors can be somewhat deceiving. And so actually putting, it's a touch screen, so putting your fingers or a stylus to actually check the areas of oxygenation is very, very important. It's important to also check the surrounding tissues as well, and to really get an average of the entire area. But you can clearly see with the colors alone that post-intervention, we were able to get a significant more oxygenation to the limb. Guiding and debridement in your office. You know, unfortunately, many of us cannot go to the OR, or a lot of my patients are unfortunately non-operable, you know, when they've had multiple procedures and they come and they're say, you know what, go to Dr. Wahab, she'll fix it. You know, we just can't take you continually back to the OR. So here we have an Achilles area. You can see here by naked eye, it's very difficult to see what is that, what's going on. Is this area going to heal? Imaging, majority of this area is blue and somewhat pale. We're not getting as much oxygenation there. Post-debridement, so it can really guide you to continue to debride. How much do you need to debride? And where do you need to debride? That could really institute greater blood flow. It's very, very important. And you can kind of just as a very obvious pictorial. This is another one you can see, and what I want to show you is that the numbers are very important as well. And sometimes you may not realize that the numbers don't need to be a significant improvement, but an improvement. So with this technology, it's very important that you start, and it's a comparison over time. Okay. Yes, you can get a snapshot. Yes, you can get an idea and an average on the one time, but really where the magic happens is when you're taking serial images over time. Serial images from your interventions, whether they be topical, whether they be surgical, it doesn't matter, but that over time. And you can see here, just with debridement alone, you can see right here in the middle, it was 67% pre-debridement and post-debridement 76%. Yeah, it looks a little bit more clean, but it doesn't look significant by the you know, naked eye on what was actually done. But we can see that also that the peri-wound is also improving as well. Also, to understand your healing trajectory, I think that's important as well. I utilize this. We have insurance contracts, right? And they want to talk to me every month about their patients and why their patients are not getting better or that they're getting better. And so I pull up a lot of these images to actually give them hard data, not just a pretty picture, because a pretty picture can be given by anybody, but really to give them hard data that no, this is a very tough case. These are probably non-healers in our trajectory of patients. And how are they healing it with our interventions? And so you can see just from March 5th to March 24th, we had an improvement over, again, I can't see by visualization. It doesn't look much different to me, but really there is an improvement over time, and it might be that slow, steady improvement, but there is something occurring. Another patient, 72-year-old male with history of diabetes, peripheral vascular disease, and he had a number of interventions, and pretty much, again, was non-operable at this point. We had healed him significantly, saved his feet. He had multiple wounds on both feet, and this was the last one left, and we are struggling. So we took an image to see what was really going on, and my concern was that his intervention had failed once again, and it does kind of look like that. But nonetheless, we went forward because again he was non-operable at this point. So what was going on in our minds was what could we put on the wound that could increase oxygenation for tissue perfusion. So you can see here that we started looking at, and I put this view here for you to understand that you don't only need to be looking at the oxygenation view, you can be looking at the total hemoglobin, the deoxygenating hemoglobin, and the oxyhemoglobin. The reason I was looking at this particularly is because, as you can see here, this image, the patient has a lot of fibrotic skin here. I didn't know if that was just some sort of glare off of the camera, what was happening. And so I wanted to really be sure that there was something a little bit more that was happening, and that we were really getting the depth of penetration that the machine really is supposed to be giving us. And so the oxygenation was obviously not so good. But we could see the total hemoglobin was there. So I could see that I don't think that this was just the error of the machine itself off of a glare, but that there was some imaging happening underneath that skin. And so what did that mean to me? So nonetheless, we started applying advanced products and hope for some recruitment of angiogenesis and recruitment of stem cells and whatnot, all of the great things that we think about when we're trying to do these interventions. And you can see here that post 7 days of an application of a product, and I'm not promoting any one product, you can see this with a variety of interventions, is that you went from this to this. And so there is movement that's occurring. And once again, justification of you using those very expensive products. And what does that mean? So on an everyday basis, it doesn't necessarily have to be for all of these clinical trials and clinical studies that we're seeing, but on an everyday basis. Now, also, when I started to tell you that my practice, we have about 15 different clinicians, doctors, surgeons, nurse practitioners, PAs, and to scale their knowledge and bring them up to par and teach is very difficult, right? I think we can all probably attest to that. So utilizing some of these also to be able for them to see their immediate response to an intervention is very important. And also for us to go back and evaluate to see if their treatment algorithms are matching everybody else's treatment algorithms is important. And it doesn't always have to be with healing outcomes. We would love to all have healing outcomes, but unfortunately, sometimes healing outcomes are not the only thing that we're looking at. Here's another one here that you can see. You can track the progression. So again, there's a skin substitute here in place that's been sutured after a debridement. And this is what we're hopeful for. We're hopeful that it goes from an area of poor perfusion to an area of greater perfusion. And obviously, hopefully in a proliferative stage and onto the remodeling stage. So you can actually visually see the stages of wound healing with our interventions. Here too, you can really pinpoint, and again, we didn't have a lot of the percentages of oxygenation on here because it kind of clouds the picture and it's very difficult to evaluate. But if you can just look at the colors alone, you can kind of see here that there's better oxygenation than in these areas. And then once the graft was more incorporated, we really got a much better outcome. Pre and post hyperbarics. We obviously have hyperbarics, topical oxygen, all of these things we talked about. Those of you that have been participant in many of the lectures, we're constantly talking about oxygen and all of the greatest and reasons why we look at oxygen. But it's very important in the premise of obviously our technology here. So there are a plethora of evidence-based studies out there talking about the technology and really utilizing it. And I think now with a lot of artificial intelligence, these are now going to be the algorithms that we need to incorporate in our own practice in order to really translate that into good outcomes. So we do have codes. They are reimbursable codes on here, but as a clinician, and not speaking only, for the company, but as a clinician, I think we really need to look at how this is going to help longer term besides just a code that reimburses, right? The codes will come and go, you'll get higher and lower reimbursement, but I do think that looking at this and extrapolating this to saying that your postoperative dehiscence rates have gone down, your complication rate has gone down. Insurance companies are absolutely looking at this and grading us. And so I think we should be on the forefront of that versus on the back end of that. So, but yes, there are absolutely codes that reimburse. So this is really just the tip of the iceberg, and we really need to evaluate what's further inside. And that what may be really lurking underneath our skin is more important.